Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. In this session, I will be discussing a very important topic in the neurology, that is the Guillain-Barré Syndrome. So, you need to know that Guillain-Barré Syndrome, what exactly is this? It is a demyelinating disorder of the central nervous system, demyelinating disorder of the peripheral nervous system, both axonal neuropathy. So let me tell you, the Guillain-Barré Syndrome, it is the disorder of a demyelinating disorder of the peripheral nervous system, right? It is a demyelinating disorder of the peripheral nervous system. Now, let me tell you, we have n number of demyelinating disorders of central nervous system, and we also have demyelinating diseases of the peripheral nervous system as well. Now, what are the examples of those? Let me explain you. Now, you take the demyelinating disorders of the central nervous system. So, the mnemonic like what we have is MINT, okay? So, what are the examples of the demyelinating disorders of the central nervous system? You take the word M. M stands for multiple sclerosis. Right? The word M stands for multiple sclerosis. And so these are all the demyelinating disorders of central nervous system, whereas Guillain-Barré syndrome, it is a demyelinating disorder of the peripheral nervous system. Okay. Now I'll give you the examples of both demyelinating disorders of central and as well as the peripheral nervous system. And you take the word I, that is infectious conditions. Okay. So we have certain infections which will cause demyelination of the central nervous system. And what are those infectious conditions? Those infectious conditions include, number one, HIV encephalitis. Right, the HIV encephalitis. Then followed by that, progressive multifocal leukoencephalopathy, that is PMLEE. Right, so these are the infectious conditions which will cause the demyelination of the central nervous system. And one more, that is Creutzfeldt-Jakob encephalitis or Creutzfeldt-Jakob disease. So these are the infections which will cause the demyelinating disorders of the central nervous system. And you take the word N. N stands for neuromyelitis optica. Right, N stands for neuromyelitis optica. And one more N is the nutritional disorders. So what are those nutritional disorders which will cause the demyelination of the central nervous system? The nutritional disorders include, number one, Wernicke's encephalopathy. Then followed by that, subacute combined degeneration of spinal cord. So subacute combined degeneration of the spinal cord, it is due to vitamin B12 deficiency. Right, it is due to vitamin B12 deficiency. And the word T is your toxic conditions or the toxins. And these particular toxins which will cause demyelination of the central nervous system include mercury. Then we have methanol. Followed by that we have toluene. And next we have certain chemotherapeutic agents. Right, CT stands for chemotherapeutic agents. So these are the examples of demyelinating diseases of the central nervous system. So you can just remember this mnemonic, that is MINT. And let me now tell you the demyelinating disorders of the peripheral nervous system. So the mnemonic what you can remember is the TAVI. Okay, what is this TAVI? It is transcatheter aortic valve implantation, which is done in patients with the aortic stenosis. Now, what are these demyelinating disorders of the peripheral nervous system? The first, you take the word T, that is toxins. Okay, and what is that particular toxin? That is organophosphorus poisoning. So organophosphorus poisoning, they will cause the demyelinating disorders of the peripheral nervous system. And you take the word A. A stands for acute inflammatory demyelinating polyneuropathy. Right, A stands for AIDP, that is acute inflammatory demyelinating polyneuropathy. And this acute inflammatory demyelinating polyneuropathy, this is nothing but the Guillain-Barré syndrome. So Guillain-Barré syndrome, it is an acute inflammatory demyelinating polyneuropathy. Then you take the word V. V stands for the vitamin deficiencies. Okay, so which particular vitamin deficiency? That is vitamin B12 deficiency. So now remember, vitamin B12 deficiency will cause demyelinating disorders of the peripheral nervous system and as well as the central nervous system. And another important is your dry beriberi. So dry beriberi, it is due to, right, it is due to vitamin B1 deficiency. And the lastly, the word what we have is the I. It is an inflammatory demyelinating polyneuropathy, right? And what is that inflammatory demyelinating polyneuropathy? That is CIDP. Okay, that is chronic inflammatory demyelinating polyneuropathy. So these are all the conditions which will cause the demyelination of the peripheral nervous system. And apart from that, even your copper deficiency, right, even copper deficiency will cause the demyelination of the peripheral nervous system. Now, out of which the topic which we are discussing now is the acute inflammatory demyelinating polyneuropathy, that is the Guillain-Barré syndrome, right? Now, if you take this Guillain-Barré syndrome, let me tell you, it is an acute motor, and we have various forms of the Guillain-Barré, like which I'll discuss now. But you need to know what type of hypersensitivity reaction is your Guillain-Barré syndrome. So, if you take the Guillain-Barré syndrome, it is an autoimmune disorder with type 4 hypersensitivity reaction. Right? It is a type of, or it is a clinical condition, or it is an autoimmune disorder with type 4 hypersensitivity reaction. Now, what is this type 4 hypersensitivity reaction? Type 4 hypersensitivity reaction is nothing but it is a delayed it is a delayed hypersensitivity reaction. That is what is your type 4 hypersensitivity reaction. Now, let me tell you all the hypersensitivity reactions, like we have totally 4 types of hypersensitivity reactions, and for that we have a mnemonic also, that is acid, right? A stands for allergic mediated, that is IgE mediated, right? Allergic mediated or IgE mediated. And the examples of allergic mediated like bee sting, latex, and certain medications like penicillin. And type 2, you take the word C, that is cytotoxic or antibody mediated, right? Examples will be your Rh incompatibility, that is hemolytic reactions, Goodpasture syndrome, and as well as the hyperacute graft rejections. And you take type 3. Type 3 is the immune complex mediated or the immune complex deposition, where it is IgG or IgM mediated. So examples of your type 3 hypersensitivity reactions will be hypersensitivity pneumonitis, systemic lupus erythematosus, polyarthritis nodosa, and as well as the serum sickness. That will be your type 3 hypersensitivity reactions. And then we have type 4 hypersensitivity reaction. So type 4 is what? It is a delayed or cell mediated type of hypersensitivity reaction. And examples will be your hypersensitivity pneumonitis, SLE, polyarthritis nodosa, serum sickness, and as well as the Guillain-Barré syndrome, like what we are about to discuss now, will be your type 4 hypersensitivity reaction. Now, after having said about what type of hypersensitivity reaction is your Guillain-Barré, let me discuss another important question. All of the following statements about Guillain-Barré syndrome are true except inflammatory pathology, demyelinating pathology, descending type of paralysis, cranial nerve involvement. Now let me discuss the features of the Guillain-Barré syndrome. So this Guillain-Barré syndrome, let me tell you, this acute condition is most common cause of acute or subacute generalized paralysis. So this Guillain-Barré syndrome, which is an acute condition, that will be one of the most common cause of acute or subacute, generalized paralysis, right? And let me tell you, this Guillain-Barré syndrome, it affects children and adults of all ages and both the genders. Okay, it affects children and as well as adults of all ages and both genders. And this Guillain-Barré syndrome, the paralysis usually follows a non-specific viral infection, right? Paralysis in Guillain-Barré syndrome usually follows non-specific viral or non-specific viral or bacterial infection by about 10 days. Okay, so initially the individual will have a non-specific viral or bacterial infection, and followed by that there will be paralysis of the entire body. And this viral infection or the bacterial infection, this may be a respiratory, right? This may be a respiratory or a gastrointestinal infection, right? This may be respiratory or the gastrointestinal infection. That is what is your Guillain-Barré syndrome. That is the basic introduction. And if you see this question now, so all of the following are true about Guillain-Barré except, let me tell you, it is an inflammatory pathology. It's an acute inflammatory demyelinating polyneuropathy, right? It's a demyelinating disorder. And they also have the cranial nerve involvement. And the most common cranial nerve which is affected is the 7th cranial nerve, that is the facial nerve. But they don't have the descending paralysis. What they have is the ascending type of paralysis will be there in patients with the Guillain-Barré syndrome. Now, you see another question. Which of the following is most common antecedent infection associated with the Guillain-Barré syndrome? See, antecedent infection, that means the individual is having prior viral or bacterial infection and followed by that there is paralysis. Now, what are the options if you see? Mycoplasma, Epstein-Barr virus infection, chlamydia infection, and then the Campylobacter jejuni. So, the most common antecedent infection associated with the Guillain-Barré syndrome will be Campylobacter jejuni, right? That will be the bacterial infection. Now, let me discuss the pathogenesis in patients with the Guillain-Barré syndrome. See, pathogenesis is already I have said that these individuals with the Guillain-Barré, they have antecedent viral or right, there is antecedent viral or the bacterial infection. Now, against this particular viral or bacterial infection, the immune system, right, the immune system will produce the antibodies. Right, the immune system will produce the antibodies against this particular viral or bacterial infection. Now, the antibodies which are formed against this particular bacterial or viral infection, they will go and attack, right, these particular antibodies. Right, these particular antibodies, they are directed against the Schwann cells within the myelin sheath. Right, so these antibodies, they are directed against they are directed against the Schwann cells within the myelin sheath, resulting in what is called demyelination. Right, resulting in what is called demyelination. So that is what is the pathogenesis, and this we call it as molecular mimicry. Now, why am I using the word molecular mimicry? That is because the antibodies which are formed against the viruses and bacteria, the same antibodies, they are acting against the Schwann cell in the myelin sheath, causing demyelination, and that is what is called molecular mimicry, right? So, Guillain-Barré syndrome is thought to result from immune response to the preceding infection that cross-reacts to the peripheral nerve, right? That cross-reacts to the peripheral nerve. And the triggering events for Guillain-Barré syndrome is Campylobacter jejuni, that is the most common organism. Right, that is the most common organism. And then followed by that, the viral infections. What are those viral infections? Like cytomegalovirus and as well as the Epstein-Barr virus and then the HIV. Right, and then the HIV. So these are the triggering events for the Guillain-Barré syndrome: Campylobacter jejuni, cytomegalovirus, Epstein-Barr virus, and then the HIV. Now, apart from these, we also have other triggering events, right? What are the other triggering events? The other triggering events include immunization, then surgery, then followed by the trauma, next bone marrow transplantation, so these are all the triggering events for the development of the Guillain-Barré syndrome. So followed by that, you see this question: earliest manifestation in Guillain-Barré syndrome is distal areflexia, facial nerve involvement, acute flaccid paralysis, urinary incontinence. Now, let me discuss the features of the Guillain-Barré syndrome and then come back to this question now. So, if you take the symptomatology in the Guillain-Barré syndrome, that includes, number one, the individual will have the weakness, right? The major clinical manifestations are the motor manifestations. Right? The major clinical manifestations are motor manifestations, and that motor manifestations will be in the form of weakness that evolves, right? The weakness that evolves more or less symmetrically over a period of several days, okay? That particular weakness. Which usually evolve more or less symmetrically, in the sense both right and as well as the left sides, they are equally affected. And this particular weakness that evolves more or less symmetrically will be there over a period of several days. And this weakness usually begins in the lower extremities. Right, this weakness, whatever is there, usually begins in the lower extremities. And from the lower extremities, the weakness will progressively move on to the trunk. From the lower limbs, the weakness will progress to the trunk. And from the trunk, the weakness will progress to the upper limbs. Right, will progress to the upper limbs. And finally, the bulbar muscles are affected. Right, finally, the bulbar muscles are affected. And this particular pattern of weakness, that is involvement of the lower limb, trunk, upper limb muscles, and finally bulbar muscles which are getting affected. This is known as ascending paralysis. Right, this is known as ascending paralysis. And if the question is asked, what will be the earliest manifestation? Right, what will be the earliest manifestation of the Guillain-Barré syndrome? The earliest manifestation of the Guillain-Barré syndrome is distal areflexia. Right, development of distal areflexia, that will be the earliest manifestation, that is absence of the deep tendon reflexes. And what will be the distal areflexia? That is absence of the ankle jerk. Right, absence of the ankle jerk, that will be the first manifestation. And let me tell you, both proximal muscles and distal muscles, they are involved relatively symmetrically, right? So both proximal and distal muscles, both of them, they are involved symmetrically, right? But asymmetry is seen in almost 9% of individuals, right? Asymmetry it is seen in almost 9% of patients, right? And the deep tendon reflexes, right? The deep tendon reflexes, they usually disappear. Right, all the deep tendon reflexes, like in the lower limbs if you take the ankle jerk and as well as the knee jerk, and in the upper limbs if you take the supinator jerk, biceps reflex and as well as the triceps jerk, all these deep tendon reflexes, they usually disappear, right? And in almost 5% of patients, right, in almost, okay, you see here, the earliest manifestation of Guillain-Barré syndrome is what? Distal areflexia, facial nerve involvement, acute flaccid paralysis, urinary incontinence. It is your distal areflexia, that is loss of the ankle jerk. That will be the earliest manifestation. And in almost 5% of individuals, so what did I tell you? They will have ascending paralysis and all the deep tendon reflexes will be lost. Proximal and distal muscles, they are usually involved symmetrically, and in 5% of individuals, the patients will have the total motor paralysis, right? 5% of patients, they develop total motor paralysis. What do you mean by the word total motor paralysis? Total motor paralysis means all the muscles are paralyzed, including the respiratory muscles. And because of the development of total motor paralysis, the individual develops respiratory failure. Right, the individual develops respiratory failure. And what type of respiratory failure does the individual develops? That is type 2 respiratory failure. And what do you mean by this type 2 respiratory failure? It is a clinical condition where the individual will have hypoxia and as well as the hypercapnia. Okay, that is what is your type 2 respiratory failure, where the individual has hypoxia and as well as the hypercapnia. So this is about the symptomatology of the Guillain-Barré syndrome. So you see this question now. What is the type of respiratory failure in Guillain-Barré syndrome? It is your type 2 respiratory failure. And why is this type 2 respiratory failure? That is because of the paralysis of the respiratory muscles. And if you take the respiratory muscles, the main muscle for inspiration is diaphragm. And the other important muscle for inspiration will be external intercostal muscle. Whereas If you take the main muscle for expiration, expiration usually is a passive process, but the internal intercostal muscles, they help in the process of expiration, right? So respiratory muscles, they get paralyzed in the advanced stages of the Guillain-Barré syndrome. Okay, so I said you that the individual will have hypoxia and hypercapnia. And because of this hypercapnia, that increased carbon dioxide will combine with water molecule, resulting in development of respiratory acidosis. Right? So there will be development of there is development of the respiratory acidosis. Okay, and why is that? That is due to carbon dioxide retention. And if the question is asked, what is the most common cause of death? Most common cause of death in patients with the Guillain-Barré syndrome will be respiratory failure. And what type of respiratory failure is that? That is type 2 respiratory failure, right? That is type 2 respiratory failure. Then followed by that, you take the cranial nerve involvement in patients with the Guillain-Barré syndrome. The cranial nerve which is most commonly affected in Guillain-Barré syndrome is the facial nerve. Okay, the most common cranial nerve which is affected in Guillain-Barré syndrome is the facial nerve. Right, it is the facial nerve. And sometimes bilateral facial nerve involvement can also occur. Right, bilateral facial nerve involvement can occur. And this bilateral facial nerve involvement, we call this as facial diplegia. Right, this we call it as facial diplegia. And we have few more conditions which will cause facial diplegia, that includes sarcoidosis, right, sarcoidosis and Melkersson-Rosenthal syndrome. So these are the two conditions where you will have the facial diplegia, that is Melkersson-Rosenthal syndrome and as well as the sarcoidosis, right? Other cranial nerves are affected, but that is later on. But the most common cranial nerve which is being affected is the facial nerve, right? And there is also the disturbance of the autonomic function. And because of the disturbance of autonomic function, the individual will have the resting tachycardia, that is sinus tachycardia, right? That is sinus tachycardia. And less often, right, less often they also have bradycardia. Right, less often they also have bradycardia. Okay, and apart from this, that is sinus tachycardia and less often bradycardia, the other autonomic manifestations include right, the other autonomic manifestations include the facial flushing, and there will be also fluctuating blood pressure. These individuals, they can have either hypertension or the hypotension. Okay, so because of the fluctuation of the blood pressure, whenever the individual develops hypotension, that we call it as neurogenic shock, right? That we call it as neurogenic shock. And there is also loss of sweating. Right, that is anhydrosis. Right, that is anhydrosis. Or episodically, they can have profuse diaphoresis also. Right, episodically, they can have profuse diaphoresis also. So that will be the disturbance of the autonomic function within the individual. So they can have sinus tachycardia and less often bradycardia. Facial flushing will be there. Fluctuating blood pressure, loss of sweating or episodic profuse diaphoresis will be there. So that will be your autonomic nervous system involvement. And even there is involvement of the urinary bladder. And that involvement of urinary bladder will be in the form of the urinary retention. Right, that will be in the form of urinary retention. And this urinary retention, it occurs in about 15% of patients. Right, this urinary retention, it occurs in about 15% of patients. Okay, that means in 85% of individuals, urinary bladder involvement is not there, but only in 15% of individuals, you have the urinary retention. Right, and in severe cases of Guillain-Barré syndrome, right, in severe cases of Guillain-Barré syndrome, there is also bladder dysfunction. Right, there is also bladder dysfunction. Then followed by that, the sensory involvement. Sensory involvement in case of the Guillain-Barré syndrome will be the cutaneous sensory deficits. Right, the cutaneous sensory deficits. And this cutaneous sensory deficits, it will be in the form of loss of pain and temperature sensation. Right, loss of pain and temperature sensation. And this loss of pain and temperature sensation, they are usually mild. Right, they are usually mild. Okay, so these Guillain-Barré syndrome patients, they have predominantly motor manifestation and very minimal sensory involvement, that is loss of pain and temperature sensation. Next, so if you see this question, which of the following statement is false regarding the Guillain-Barré syndrome? The facial nerve palsy, proximal muscle involvement or proximal muscle weakness, areflexia, pyramidal signs, the distal muscle weakness. So which of the following is the false statement in this individual? So false statement is that in these patients with the Guillain-Barré syndrome, they have the distal muscle and as well as the proximal muscle weakness, both of them, they occur simultaneously. Right, both of them, they occur simultaneously. Proximal muscle weakness and distal muscle weakness, they don't occur separately. Initially there will be distal muscle weakness, but within a period of time there will be proximal muscle weakness. So both of them are equally affected. So distal muscle and proximal muscles, both of them, they are equally affected in patients with the Guillain-Barré syndrome. Next, you see another question. True statement about the Guillain-Barré syndrome is all except demyelinating disorder, prior viral infection, prior bacterial infection, predominant sensory involvement. Let me tell you, in Guillain-Barré syndrome, you don't have a predominant sensory involvement, will not be there. Right? They have predominantly motor manifestations and they have demyelination, they have prior viral infection and they also have the prior bacterial infection as well in this individual. But predominant sensory involvement is not the feature of the Guillain-Barré syndrome. Next. Now the next question is, which is the most common form of the Guillain-Barré syndrome? Acute inflammatory demyelinating polyradiculoneuropathy, Miller-Fisher syndrome, acute motor axonal neuropathy, acute sensory motor neuropathy. Now, if you take this Guillain-Barré syndrome, right, as such, historically it is considered as a single disorder, but now it is considered as the heterogeneous syndrome with several variant forms, right, with several variant forms. And out of that, the major forms are AIDP, right? AIDP stands for acute inflammatory demyelinating polyneuropathy, right? That will be your AIDP. Then the other important form is MFS, that is Miller-Fisher syndrome. And the third important form will be AMAN, that is acute motor axonal neuropathy. Right, AMAN, that is acute motor axonal neuropathy. Then we have AMSON or ASMAN, that is acute sensory motor axonal neuropathy, right? So that will be your ASMAN. So these are the major forms of the Guillain-Barré syndrome, out of which the AIDP, that is acute inflammatory demyelinating polyradiculoneuropathy, that will be the most common form, right? So which is the most common form of Guillain-Barré syndrome? That will be the AIDP, that is acute inflammatory demyelinating polyradiculoneuropathy. Now, followed by that, you see another important question. Conduction velocity of the nerve is reduced in all of the following conditions except acute motor axonal neuropathy, acute inflammatory demyelinating neuropathy, hereditary sensory motor neuropathy, multifocal motor neuropathy. Now, let me discuss the conduction velocity is not reduced in which condition. So the question is like conduction velocity of the nerve is reduced in all of the following conditions except, that means in which condition it is not reduced. It is not reduced in case of acute motor axonal neuropathy. In AMAN, the conduction velocity of the nerve is not reduced. Now, nerve conduction studies, they play a very important role in the diagnosis of the Guillain-Barré syndrome. So, if you take the nerve conduction studies, let me tell you that there is preserved conduction velocity right? Preserved conduction velocities, it's a very important feature of axonal neuropathy. Right? It is an important feature of the axonal neuropathies. Right? And in case of axonal neuropathies, there is no reduction of conduction velocity, or there may be a minimal reduction of the conduction velocity. And what is the example for that? That is your AMAN, that is acute motor axonal neuropathy. So acute motor axonal neuropathy, it is a pure axonal neuropathy which is characterized by normal motor conduction velocity. Right, normal motor conduction velocity. Okay, now whereas you take in case of demyelinating neuropathies, so in case of demyelinating neuropathies, they are typically associated with, right, they are typically associated with reduced conduction velocity. Right, they are typically associated with reduced conduction velocity. And what are those demyelinating neuropathies? That includes acute inflammatory demyelinating polyneuropathy, then hereditary sensory motor neuropathy, then multifocal motor neuropathy. These are all the demyelinating neuropathies, right? These demyelinating neuropathies, they are characterized by reduced conduction velocities. Right, they are characterized by reduced conduction velocity on the nerve conduction studies, whereas acute motor axonal neuropathy, there is preserved conduction velocity, whereas in AIDP, hereditary sensory motor neuropathy and multifocal motor neuropathy, these are all demyelinating neuropathies where you have reduced conduction velocities. Now, if you see the differences between the demyelinating versus the axonal neuropathies, see, the primary function of the myelin sheath, right, the primary function of the myelin sheath is to increase the axonal conduction. Right, is to increase the axonal conduction velocity. Right, without significant increase in the axonal diameter. Axonal diameter need not be increased in order to increase the conduction velocity. So the primary function of myelin is to increase the axonal conduction velocity without a significant increase in the axonal diameter. Now, what happens here is, because of the myelin sheath, the impulse from one particular nodes of runware, it will jump onto the another node of runware. Right, it will jump from one node of runware to another node of the runware. Okay, and this particular type of conduction, it is called saltatory conduction. Right, this particular type of conduction is called saltatory conduction, in which the nerve impulses, they jump between the electrically excitable regions of the axon, which is called the nodes of runware. Right, and these nodes of runware, they are located between electrically insulated areas. Okay, so that is what is the function of the myelin sheath. Now, whenever there is a demyelinating process, in demyelinating process, what happens once there is once there is demyelination, this demyelinating process disrupts the normal saltatory conduction. Right, it disrupts the normal saltatory conduction. Okay, that's a way, which one, whenever there is demyelination. So once the normal saltatory conduction is disrupted, some axons within the nerve slowing the conduction velocity of these axons. So basically, once your saltatory conduction is lost, there will be slowing of the conduction velocity. So as demyelination process, it becomes more profound, the conduction through some areas is blocked completely, right? That we call it as the conduction block. Right, that we call it as the conduction block. Whereas you take in case of axonal neuropathies, in axonal neuropathies, the conduction velocity is typically either preserved or minimally reduced. But whereas in demyelinating pathologies, the conduction velocities are grossly reduced. Right, so that's an important difference between the demyelinating and as well as the axonal neuropathy. Next, now you take one important form of the Guillain-Barré syndrome, that is the Miller-Fisher syndrome. You need to know what is the most common cranial nerve which is affected in case of the Miller-Fisher syndrome. 7th nerve, 3rd nerve, 6th nerve, 10th nerve. Let me tell you, in case of Guillain-Barré syndrome, that is in acute inflammatory demyelinating polyneuropathy, it is the seventh nerve, and that too bilateral seventh nerve palsy will be there. But in case of the Miller-Fisher syndrome, let me tell you, the most common affected nerve is the third cranial nerve. Right, the most common affected nerve is the third cranial nerve. And this Miller-Fisher syndrome, let me tell you, it is one of the rare variety of the Guillain-Barré syndrome, and the cranial nerves, they are affected first. Right, the cranial nerves, they are affected first, and the most common affected cranial nerve will be the third cranial nerve. Right, most common affected nerve will be the third cranial nerve, and in these individuals you have a characteristic triad. What is that characteristic triad? That is OAA. What is this OAA? That is ophthalmoplegia, then second A is areflexia, and third is ataxia. So this is what is your OAA, ophthalmoplegia, areflexia, and then ataxia. And this is also an autoimmune disorder, right? Autoimmune disorder means you should have the antibodies. The antibodies that you have here is anti-GQ1 antibodies, right? The antibodies that you will have here is anti-GQ1 antibodies. So that is about the Miller-Fisher syndrome, right? It is a rare variety. Cranial nerves are affected first, and the most common affected nerve is the third cranial nerve, and it is characterized by a triad, that is ophthalmoplegia, areflexia, and ataxia, and the antibodies that you will have is anti-GQ1 antibodies, right? Now, and after having discussed about the Miller-Fisher syndrome, you see another question. All of the following are the features of Guillain-Barré syndrome except predominant motor involvement, residual disability, absence of pleocytosis in cerebrospinal fluid, sparing of the bladder function. Let me tell you, in these patients, how will be the prognosis, right? After discussing the prognosis and all, I'll come back to this question again. So, if you take the prognosis of the patient with the Guillain-Barré syndrome, these clinical course of Guillain-Barré syndrome, it is usually a benign. Right, the clinical course, it is usually benign, and spontaneous recovery begins within 2 to 3 weeks. Right, spontaneous recovery usually begins within 2 to 3 weeks. Right, that means the prognosis is good, and most of the patients, they regain full muscular strength, although some are left with residual weakness. Right, most of the patients, they regain full muscular strength, right? And although some are left with residual weakness, right? Only few, but majority of them, they don't have residual weakness at all. And how will be the recovery? Let me tell you, the recovery occurs in the reverse fashion. That means whatever has lost, whatever the motor function which has been lost in the later stages of the disease or in the later part of the disease, that will recover first. So what is that which will recover first? The recovery will be the bulbar functions first. Okay, so recovery, it occurs in inverse fashion. right? Recovery, it occurs in inverse fashion. So there will be recovery of there will be recovery of the bulbar functions first, and after the recovery of the bulbar function, later the upper limbs will recover, then the trunk muscles will recover, then the muscles of the lower limbs will recover. Right, the muscles of the lower limbs will recover, and recovery of the lower limb muscles, it is last, right? It is last. Okay, and if you take the mortality rate in these individuals, mortality rate, it is 5%. Why? It is only 5% of individuals which may land up into total motor paralysis, that is respiratory paralysis. Okay, and after the muscles they recover their strength, the deep tendon reflexes, right, the deep tendon reflexes, they are last to recover. Right, the deep tendon reflexes are last to recover. Please remember, it's a very, very important point. Okay, and in 5% of individuals, I said you that there is mortality. And what is the cause of mortality? Right, what is the cause of mortality in these 5% of patients? The cause of mortality is bulbar and respiratory involvement. Right, bulbar and respiratory involvement, they are the one which may make the individual to land up in death. Okay, so that is about the prognosis. So ultimately, how is the prognosis? This is a condition with a good prognosis. Right, you know, sometimes even though you don't treat, within a span of 4 to 8 weeks, they have complete recovery. But even though if you don't treat, when they are able to recover, why is that we are treating then? Because we don't know who is that particular 5% of patients. And if you leave like that, the individual may develop severe respiratory muscle weakness and the individual will die. So that is the reason why definitely we have to treat this patient. And coming to the investigations. So, one, I have already taught you about the nerve conduction studies. Right, just before the prognosis, I have taught you about the nerve conduction studies. What they have is demyelinating pathology, and nerve conduction velocities will be reduced if it is a demyelinating pathology. If it is like acute motor axonal neuropathy, the velocity reduction will not be there. And the next important thing is lumbar puncture and then the CSF analysis. So, how will be the opening pressure in these individuals? The opening pressure in patients with the Guillain-Barré syndrome will be normal, and apart from that, glucose and cells, these are also normal. And the CSF findings, they are distinctive in the Guillain-Barré syndrome. That is, there is dissociation between the cells and as well as the CSF protein. Right, that there is dissociation between the cells and proteins in the CSF. Okay, and what is the dissociation between the cells and protein within the CSF? They have cells, they are not increased, right? So there is, right, there is acellular response, or there is lack of cellular response. Whereas proteins, if you see, there is gross increase in the CSF proteins, right? So the proteins, they are grossly increased. And what is that called as? That we call it as albuminocytological dissociation, right? That we call it as albuminocytological dissociation. So what does that mean? The albumin levels are very high compared to that of the cells, right? There will be elevation in CSF protein without accompanying increase in the cells, right? Elevation of CSF proteins without increase in, right, without increase in the number of cells, and that we call it as the albuminocytological dissociation, right? And the normal cell count is such a characteristic of Guillain-Barré syndrome that if there is sustained pleocytosis, it suggests an alternative diagnosis. Pleocytosis will not be there. What do you mean by the word pleocytes? They are nothing but the WBCs. So there is no right, there is no pleocytosis. That means there is no increase in the WBCs, right? So they have characteristic albuminocytological dissociation. So this albuminocytological dissociation, it is also seen in another clinical conditions like Freund syndrome, right? Like Freund syndrome. What is Freund syndrome? Freund syndrome is a clinical condition which is characterized by a spinal block, right? Which is characterized by a spinal block. And this particular spinal block, it is due to tumor or tuberculosis of the spine, right? This particular spinal block, which is nothing but your Freund syndrome, it is due to tumor or tuberculosis of the spine. And the other investigations, nerve conduction studies, just now I have discussed. You have demyelinating pathology, latency period of the F reflex is increased, MRI of the spine also shows the demyelination, and investigation of choice will be anti-GM1 antibodies. Basically, it's a molecular mimicry. The antibodies which are directed against the bacteria and viruses, these antibodies, they go and cause the demyelination. And another important antibodies are anti-GQ1 antibodies. These anti-GQ1 antibodies, where is that you will find? That is in Miller-Fisher syndrome. Okay, so that is about the investigations in patients with the Guillain-Barré syndrome. Now let me discuss the diagnostic criteria. See, in the diagnostic criteria, we have required criteria and we have the supportive criteria. Now what are these? I will discuss. So if you see the required diagnostic criteria, so we have required criteria and as well as the supportive criteria. The required diagnostic criteria for Guillain-Barré syndrome is number 1, progressive weakness of 2 or more limbs due to neuropathy. Right, progressive weakness of two or more limbs due to neuropathy. And the second important required diagnostic criteria is areflexia, that is absence of the deep tendon reflexes. And third important diagnostic criteria is that the disease course should be disease course should be less than 4 weeks and exclusion of other causes. Right, exclusion of the other causes. So these are the required diagnostic criteria for Guillain-Barré syndrome. progressive weakness of 2 or more limbs due to neuropathy, areflexia, disease course should be less than 4 weeks, and exclusion of the other causes. What are the other causes that has to be excluded out? Vasculitis has to be ruled out. Toxins like organophosphates, lead, botulism, diphtheria has to be ruled out. Porphyria has to be ruled out. Localized spinal cord or cauda equina syndrome have to be ruled out. So that is about the required diagnostic criteria in case of the Guillain-Barré syndrome. And what are the supportive criteria? There should be relatively symmetrical weakness, both right and left side, they are equally affected. And there should be only minimal or mild sensory loss, that is loss of pain and as well as temperature. And if you take the facial nerve involvement, facial nerve or other cranial nerve involvement will be there, and this facial nerve involvement, it should be bilateral, right? So there will be what is called facial diplegia, and there should be absence of the fever, and there should be typical CSF finding, that is albuminocytological dissociation. And what is the differential diagnosis for this albuminocytological dissociation? That is the Freund syndrome. And nerve conduction studies, there should be evidence of demyelination. So these are the supportive criteria. Now going back to the question which I have shown you in the beginning, all of the following are the features of Guillain-Barré syndrome except predominant motor weakness, yes, it will be there. Residual disability will not be there, right? Almost like 90-95% of individuals, they recover, right? And very few people, they have the residual weakness, okay? And absence of pleocytosis in CSF, it's a true statement, right? Albumin levels will be very high and WBCs, they are not increased. Sparing of bladder function is also true. See, almost 85% of individuals, the bladder function is retained, but only in 15% of individuals, there is bladder retention. That means in majority of the patients with the Guillain-Barré, they have the sparing of the bladder function. Now, after having discussed about the diagnosis and as well as diagnostic criteria, let me discuss the treatment, right? What are the drugs, what are the treatment options for the Guillain-Barré syndrome? See, in patients with Guillain-Barré syndrome, supportive care is extremely important in Guillain-Barré syndrome. And in up to 30% of patients, they develop neuromuscular respiratory failure requiring mechanical ventilation, okay? So, supportive care. Right, supportive care is extremely important, and that supportive care is mainly in the form of the mechanical ventilation. Right, mainly in the form of mechanical ventilation, okay? Now, this mechanical ventilation is the one which helps the patient to prevent the development of the respiratory failure, because these patients, they are having total motor paralysis where there is respiratory muscles not showing their adequate function of respiration. That will be the one which requires mechanical ventilation, okay? Next, now the other important thing is the disease modifying treatment or the disease modifying drugs you have to give. So the main modalities of therapy for Guillain-Barré syndrome include, number one, the plasma exchange, right? The plasma exchange, and this plasma exchange, which is also called as plasmapheresis, and administration of a drug. And what is the drug that need to be administered? Administration of intravenous immunoglobulin, right? Administration of intravenous immunoglobulin. And this intravenous immunoglobulin, this is considered as the drug of choice, right? This is considered as the drug of choice in patients with the Guillain-Barré syndrome. Now, let me discuss about the plasmapheresis and then intravenous immunoglobulin. See, plasmapheresis is that where you do the plasma exchange. So, with the plasma exchange, there is early improvement in muscle strength. Right, with plasma exchange, there is early improvement in there is early improvement in muscle strength, and please remember the plasma exchange will reduce the need for mechanical ventilation. Will reduce the need will reduce the need for mechanical ventilation, and there will be better recovery. There will be better recovery with plasmapheresis. And the another important drug of choice, what is that we have discussed, that is intravenous immunoglobulin. Intravenous immunoglobulin, the efficacy wise, if you see, it is similar to plasmapheresis. It is similar to plasmapheresis. Okay, and these patients, patients with more severe clinical disease, they may benefit from longer duration of IVIG treatment. Okay, so patients with more severe disease, they benefit from longer duration of intravenous immunoglobulin treatment. And what will be the dosage of intravenous immunoglobulin? The dosage is 400 milligrams per kg per day. And this intravenous immunoglobulin you have to give for 5 days. You have to give for 5 days. And these patients, they have to be admitted to the intensive care units if their forced vital capacity is declining, and intubation is considered if forced vital capacity reaches 15 ml per kg. So, once the forced vital capacity is reducing, immediately these patients have to be shifted to the intensive care units, And when the forced vital capacity, if it is less than 15 ml per kg, if it is less than 15 ml per kg, they have to be put on mechanical ventilator. They have to be put on mechanical ventilator. So that is about the intravenous immunoglobulin. The dosage is 400 milligrams per kg per day, and that too 5 days it have to be given. And the efficacy wise, it is similar to that of plasmapheresis. Then why is that you consider the intravenous immunoglobulin to be the drug of choice? Okay, so first and foremost, very important, the treatment with intravenous immunoglobulin or plasmapheresis, whatever it is, this should be initiated as soon as the diagnosis is made. So immediately this intravenous immunoglobulin should be administered, and this intravenous immunoglobulin, which is nothing but immunotherapy, will not be effective if it is initiated 2 weeks after the first motor symptom. So not effective. Which one? The intravenous immunoglobulin is not effective if it is initiated, if it is initiated 2 weeks after first motor symptom. Okay, and next point, you see, either high dose intravenous immunoglobulin or plasmapheresis, they may be initiated. Anything you start, either of it you start, because they are equally effective. But why we consider the intravenous immunoglobulin as a drug of choice? Because of the ease of administration. It is easy to administer than compared to that of the plasmapheresis. Okay, but don't give combination. A combination of both therapies is not significant. Then either you're giving the drug alone. So you have to give either IVIG or you need to do plasmapheresis, but don't give both of them simultaneously. right? So why is it the IVIG, why is it preferred as an initial therapy? Because of the ease of administration, and it also has a good safety record. Right, it has good the safety record. Okay, that is about the administration of the intravenous immunoglobulin. And you need to know what are the poor prognostic features in patients with the Guillain-Barré syndrome. So if the age of the individual is more than 40 years, it is considered to be a poor prognostic factor. And if the individual has poor upper limb muscle strength, right, if the individual has poor upper limb muscle strength, that is also considered to be a poor prognostic feature. And if the individual has previous history of diarrheal illnesses, right, past history of diarrheal illnesses, specifically with Campylobacter jejuni, right, specifically with Campylobacter jejuni infection, it is considered to be a poor prognostic factor, because you know the Guillain-Barré syndrome can be secondary to cytomegalovirus infection, Epstein-Barr virus infection, and as well as HIV infection. But if it is secondary to Campylobacter jejuni infection, they are considered to be having the poor prognosis. And if there is high anti-GM1 antibody titer, right, if there is high anti-GM1 antibody titer, that is also considered to be a poor prognostic feature. And those individuals who are in need of ventilatory support, right, who are in the need of ventilatory support, even they are considered to be a poor prognostic feature. So these are all the poor prognostic features in patients with the Guillain-Barré syndrome. If they are there, the outcome is slightly less. There may be residual weakness. Now, you see another question. All of the following statements regarding the treatment of Guillain-Barré syndrome are true, except corticosteroids may be used for early recovery and prevent the long hospital stay. High dose intravenous immunoglobulin can be initiated. Plasmapheresis can be done. High dose intravenous immunoglobulin and plasmapheresis are equally effective. So, which is the incorrect statement here? The incorrect statement is the corticosteroids may be used for early recovery and prevent the long-term hospital stay is a wrong statement. Let me tell you, corticosteroids, they have no role in the treatment of the Guillain-Barré syndrome. Now, why is that? Why? Because you see, the infection, the disorder of Guillain-Barré syndrome is almost 2 weeks prior infection. So initially the individual will have the infection by Campylobacter jejuni or viral infection, and our immune system will fight with the organism and will form the antibody, and that particular antibody will attack the myelin sheath, right? That particular antibody will attack the myelin sheath. So the antibodies have been formed almost like 2 weeks back. So if you give corticosteroids now, they are of no use. Right? Corticosteroids, they are immunosuppressive, they prevent the antibody formation. But now the antibodies are not newly forming here. Already the antibodies have been formed in patients with the Guillain-Barré syndrome. So that is the reason why corticosteroids may be used for early recovery and prevent long-term hospital stay. It's a wrong statement. So to summarize the entire Guillain-Barré syndrome, let me tell you, Guillain-Barré syndrome, it's an acute autoimmune fulminating demyelinating polyradiculoneuropathy which occurs 1 to 3 weeks after an acute infection process, and that is usually gastrointestinal or the respiratory infection, right? And these individuals, they have the motor, sensory and autonomic manifestations, but sensory manifestations, they are very mild sensory involvement, that is loss of pain and temperature. Motor manifestation, you know, they have the rapidly evolving motor paralysis, and that too ascending paralysis. There will be distal areflexia, that will be the earliest manifestation, and symmetrical weakness, flaccid paralysis, because it's a lower motor neuron type of paralysis. That is the reason why it is a flaccid paralysis, and sphincter tone is normal. And in almost, you take the facial nerve, the cranial nerve which is being affected is the facial nerve, right? And life-threatening respiratory paralysis requiring mechanical ventilation may be seen. And what about sensory involvement? Sensory involvement, they have mild sensory involvement. And autonomic involvement is common. And that will be in the form of resting tachycardia, orthostatic hypotension, profuse diaphoresis, right? And there can be even the cardiac dysrhythmias. So these are the autonomic manifestations that you will see in patients with the Guillain-Barré syndrome. And if you take the CSF studies, so CSF studies, they show the evidence of albuminocytological dissociation. That means the albumin levels will be very high and there is no pleocytosis at all, right? And how will be the overall prognosis? Recovery is usually remarkable in Guillain-Barré syndrome, and approximately 85% of patients with Guillain-Barré syndrome achieve a full functional recovery within several months to a year. And the treatment, it is intravenous immunoglobulin that is considered as the drug of choice. So that is about the treatment of the Guillain-Barré syndrome. And supportive therapy is also very, very important. And what is that supportive therapy? That is in the form of mechanical ventilation and as well as the chest physiotherapy. So this completes the discussion of the Guillain-Barré syndrome. And what did I tell you? Glucocorticoids, right? They have no role in the treatment of the Guillain-Barré syndrome. Now, if you see a question on this, all of the following are true about Guillain-Barré except ascending paralysis, flaccid paralysis, sensory level, albuminocytological dissociation. Ascending paralysis is a true statement. Flaccid paralysis is a true statement because it's a lower motor neuron type of paralysis. Albuminocytological dissociation is a true statement. But sensory level will not be there in these patients with the Guillain-Barré syndrome, right? Another question, you see, a child presents with ascending paralysis. There is subsequent respiratory muscle involvement. CSF examination shows albuminocytological dissociation. What is the treatment of choice? Cycloserine, oral prednisolone, intravenous methylprednisolone, intravenous immunoglobulin. So, ascending paralysis, subsequent respiratory muscle involvement, and CSF examination showing albuminocytological dissociation. What is this suggestive of Guillain-Barré syndrome? And what is the drug of choice? That will be intravenous immunoglobulin. So please remember, cycloserine, it is a GABA transaminase inhibitor and it's an antibiotic which is also used in the treatment of the tuberculosis, right? Which is also used in the treatment of tuberculosis. So cycloserine, it's an incorrect statement. It's an anti-tubercular drug. Okay, and corticosteroids, I said you there is no role in the treatment of the Guillain-Barré syndrome at all. Okay, now what is the indication of intubation in patients with the Guillain-Barré syndrome? Forced vital capacity reduced to 15, 30, 40, 50. Forced vital capacity when it is reduced to 15 ml per kg, that is the indication for intubation in these patients with the Guillain-Barré syndrome. Right? So with this, I'm done with the topic of Guillain-Barré syndrome. Thank you very much.